In many rural communities across Africa and Asia, humans and free-roaming dogs live in close daily proximity. This overlap routinely leads to close interactions. A startled animal might leave a minor nip or scratch on a child's leg, an injury so small it barely warrants a bandage. Because children frequently fear being reprimanded, they often hide these minor bites from their parents. The wound goes unwashed, and the local clinic is never consulted. But a broken layer of skin is a microscopic gateway. It allows infectious viral particles to bypass physical defenses and enter the underlying tissue. The true threat of this pathogen lies in this quiet entry. It weaponizes silence, starting a biological countdown long before anyone suspects the patient is in danger. Unlike blood-borne viruses that trigger massive immune responses, the lysovirus, the pathogen that causes rabies, takes a protected route. It hijacks the peripheral nervous system. Once inside a nerve ending, the virus inches its way up the peripheral nervous network. It travels slowly, completely hidden from the body's standard immune cells, heading straight for the brain. The biological reality of this progression is absolute. Once the virus breaches the central nervous system and clinical symptoms appear, the outcome is invariably fatal. Yet, the disease is entirely preventable. A timely course of post-exposure prophylaxis neutralizes the virus before it can establish a foothold in the nervous system. When a patient dies from rabies, the science hasn't failed them. A sequence of human, logistical, and systemic delays simply allowed the clock to run out. Globally, more than 95% of these deaths occur in Africa and Asia, falling heavily on rural communities with limited access to care. This table displays the reported human rabies deaths submitted to the World Health Organization between 2022 and 2024. Looking specifically at the row for the African region, the official numbers hover around 1,500 deaths a year. These official figures obscure the actual burden. Weak surveillance networks and frequent misdiagnoses mean the vast majority of cases are never formally recorded. Epidemiological models reveal the scale of this blind spot. In Africa, for every single rabies case documented in official records, an estimated 300 cases go entirely undetected. Without accurate data mapping the true spread of the disease, public health systems cannot direct life-saving resources to the communities that need them most. For a rural family, seeking treatment requires overcoming immense geographical and financial barriers. Reaching a clinic often means securing transport over long distances, and the out-of-pocket costs for treatment can climb into the hundreds of dollars. Even if a patient reaches a medical facility, the necessary biologicals are frequently missing. Critical supplies, particularly rabies immunoglobulin for severe exposures, suffer from chronic shortages or are entirely absent from local medical cold chains. This chart outlines reported obstacles to detecting and treating rabies. The bottom bars highlight lacking testing capacity and untrained clinical staff. Moving up, a lack of public awareness and limited funds mean many families never recognize the need for treatment. The medical safety net is fractured across multiple failure points. By the time the virus reaches the brain, the healthcare system has already missed several crucial opportunities to intervene. To close these gaps, the World Health Organization and its partners launched the 0 by 30 strategy. It is a coordinated global effort demanding action across different sectors of government. A core component of this strategy is integrated bite case management. When a patient arrives at a clinic with a bite, the human health workers immediately notify veterinary authorities to track and investigate the animal involved. This shared intelligence allows doctors to make precise, risk-based decisions on administering vaccines. It can serve scarce clinical supplies while simultaneously identifying other people in the community who might have been exposed to the same animal. While post-exposure treatment saves human lives, stopping the virus at its source requires mass dog vaccination. Immunizing the local canine population breaks the transmission chain before a human is ever bitten. This One Health model aligns medical care and veterinary science. It moves communities away from reacting to fatal exposures and towards proactively eliminating the virus from the environment. International partnerships are now expanding access to the necessary biologicals. Global financing mechanisms allow eligible countries to request dedicated support for human rabies vaccines, stabilizing local supply chains. Health ministries are also transitioning to intradermal injection regimens. These updated protocols require fewer clinic visits and use a fraction of the vaccine volume to achieve full immunity, drastically reducing costs. When a minor bite occurs in this supported framework, the outcome changes. The child tells their parents, the local clinic has the vaccine in stock, and the animal is investigated by trained professionals. Rabies is an ancient disease with a 100% fatality rate once symptoms appear. With accurate surveillance, sustained dog vaccinations, and accessible clinics, eliminating human deaths by 2030 is a strictly logistical challenge that can be solved.